my name is Gabe. I'm one of three pediatric blood and marrow transplant social workers at the University of Minnesota. And so the social workers on the BMT team, we work closely. Oh, there we go. Thank you, Megan. All right, next slide. So here are some objectives for today's. Just talk about the clinical social work role within the BMT program, and talking about three different types of supports that social workers provide within the team, the context of the medical team. And then by the end of this, hopefully you could conceptualize and understand, okay, well, what is a situation in which we will utilize a social worker? Because that's a common question when families and patients come through our program and say, well, we've never interfaced with a social worker. And so in what ways will you be helpful during our journey? And so hopefully I'll talk about some of that. All right. So this is a kind of a funny illustration. So there's what do social workers do? It's kind of a gray job and we wear many hats. So on the top left, we have Olivia Benson and Elliot Stabler from Law and Order. So that's one perception of social workers. Mother Teresa. We have all these different illustrations. But at the end, that's really what we do is we help people and we help people help themselves. It's kind of the gist of social work. So yeah, that's kind of that slide there. All right, so the role of a social worker in the BMT program is we support the emotional needs of patients and the coping of patients during their transplant process, conducting assessments pre-treatment to kind of assess, caregiving, need for resources, support system, financial needs, barriers, sibling supports, and really looking at the family system, because yes, it's a patient going through transplant, but it really affects the whole family system, and really having that fundamental social work approach of a systems approach. That's kind of our approach specifically with transplant because it's such an intensive treatment. And helping with adjustment to illness and treatment, and psychosocial support, but specifically kind of the grief counseling. That's, I guess, what I'll call it. Grief related to new diagnoses, adjustment, and really just the course of transplant can lead to a lot of hardship. For instance, discovering some of the limitations, for instance, associated with transplant. And you think, okay, well, I'm gonna play sports in the fall, and you find out during the transplant process, they may not be a possibility, or even going back into the classroom and having to do remote education for a while, or it's an adjustment, and just really trying to support patients and families through that adjustment. Teaching relaxation techniques, communication, coping. Again, we work very closely with Megan's team, the integrative therapies team, and really trying to figure out, okay, how are you supporting the family? How are we supporting the family? How do we marry the two? Because we ultimately, we all have the same goal as part of the psychosocial team. Helping with problem solving, logistics. A lot of our patients come from all over the country and different countries, so traveling internationally for transplant. And so we're involved early on in the process and helping navigate the logistics related to transplant. So the first thing, okay, well, you're gonna go to Minnesota. Okay, where's Minnesota? They look it up on the map. Okay, and they look at the first thing they comment on is, how many inches of snow do you got? Whoa, okay. And then you kind of get into the nitty gritty. How are we going to make this work? And so family separation, job loss, loss of income, school disruption, social disruption, and really trying to understand, okay, what are the logistical aspects, and then kind of going a layer deeper and saying, now how are we going to apply the resources that we have on hand to support your family through your journey? And facilitating educational support, so referral for education services while here if they're school aged, and then providing resources needed to support families, including federal kind of programs and Social Security, and navigating Medicaid and community programs. So we kind of are like, like a good resource for families and understanding, okay, here are some programs to look into early on and to investigate, and then just kind of helping them along that process. Thank you. All right, so education and experience. So we're all licensed clinicians, and so we're licensed by the state of Minnesota at the highest clinical level, because it's a very clinical job, and we're very mindful of that as we do the hiring for the position to ensure that we have appropriately trained and skilled clinicians to work with this highly special population. BMT process. So initially there's a new consult referral, and during that consult, social workers will meet with the family as part of the consult. So it goes doctor, nurse, social worker. By the time they meet the social worker during the consult evaluation process, there are so many questions. How are we going to make it work? Logistics, where are we going to stay? The costs. And really, we're providing a lot of education during that visit. It's about an hour and a half. And as part of that consult, we bring families to the unit and do a walkthrough, and we're providing education during that visit, but we're also assessing, okay, what are maybe some of the needs that come up, or anxieties or questions, and really trying to ensure that time where they're traveling here for a day or two, that they make the most out of their visit. And so that's one of the visits I enjoy most, because there's so much support to be provided during that acute stage. But also a lot of education, because it's a huge adjustment coming, because some families know of the diagnosis, or some have known of the diagnosis for many years and just been following, and now is the time to come to transplant. So there's so much anticipation. So it's a pretty powerful visit, the evaluation. And then after that point, folks go home, and then they come back prior to transplant for a workup evaluation. So it's a lot of physical tests and also, neuropsych, and we also meet with them and do what's called a psychosocial assessment. That again is about an hour and a half. We sit down and talk through the nitty-gritty of transplant and how are we going to best support your family through this journey. And then when patients are admitted, we visit with them about once or twice a week, depending on need. Similar to integrative therapies, just providing support tailored to that individual patient and family system. So sometimes we're doing a lot of support for patients. Sometimes we're doing a lot of support for parents who are struggling throughout the process. It just kind of depends on each family. And then discharging locally, and from that time, the timeline is typically 100 days. So yes, you discharge from the hospital, but you have frequent follow-up. And just kind of helping families navigate discharge, but also being prepared to come to clinic, managing many medications, a lot of stress, many times a week, and just being that consistent figure to provide support for caregivers who often experience fatigue and some of those concerns. And then the possibility of hospitalization after discharge due to fevers and complications, and just supporting families through that. And then once families return home, we say once a BMT family, always a BMT family. So we get calls from people who are 5 years out, 2 years out, 10 years out, and looking for different resources and supports. And we actually enjoy those phone calls because they have such a close relationship with the transplant program, even years after treatment. So types of support offered. So talking to families by phone or in person. Of course, this is pre-COVID. After COVID, we're doing a lot by phone, and now beginning to do more in person. And help with travel near or far. So whether you're traveling, from rural Minnesota or from the East Coast, just really helping with the logistics piece. Answering questions regarding logistics, resources, parental counseling support for anxiety, grief and loss, or anticipated loss, and reassuring families that they're not alone, and kind of facilitating the peer-to-peer support We've even designed and implemented a caregiver support program at the Ronald McDonald House where social workers go out there once a month, and we facilitate a peer support group for only parents. And it's not only BMT patients and caregivers, it's HEMOC, cardiac, and different diagnoses, and they all come together and they talk about some of the common themes among caregiving for a child with an illness. And what we found is that despite the diagnoses per se, there's those common themes and a great benefit to do more, because the feedback initially has been that it's been extremely therapeutic. So we want to do more of that. So during pre-transplant evaluation, so again, we're doing a lot of the logistical support, and we do the tour of the unit with the family, answering questions, and really even assessing gaps for information. So some families say, man, that consult was great, and after the 30 days, we'll go home, and they say, wait, what happened? And we realize, okay, there's some gaps in understanding. So how do we facilitate another conversation with the physician, because there seems to be a misunderstanding. Family believes, their stay will be 30 days, but then what the physician was explaining was the hospitalization is 30 days, but then the treatment duration is 100. And that's a big difference. And so part of the visit is really trying to assess, okay, what really is your understanding, and how do we help fill in the gaps, or get the doctors or nurse to come back around and fill the gaps. And a little bit of just, I don't want to say, some families are shopping around. They come to the U, they go to Philly, they go to, they're in Texas, and they really want to figure out what facility is best for me. And we really try to stress the expertise at the University of Minnesota being the pioneers of transplant. And the numbers are there, but also the passion of the physicians is something that you can't deny, and that's something that we want families to understand and take with them, and feel good about their choice to come to the University of Minnesota. During outpatient workup, again, we do the psychosocial assessment, assist with travel as they come back to our facility for those evaluations. But also keeping in the back of our mind, some people come to workup, but then they don't necessarily come through for transplant. There are some complications that delay or prevent them from moving forward. So yes, we're assessing for transplant, but we're also there just to be a support person, because workup is a high anxiety phase of the treatment, because there are some uncertainties related to it. And just kind of helping families acclimate to the new environment, whether it's beautiful weather like this or the depth of winter, and you're coming from a different climate. There are things like that we just want to support families in their acclimation to the new environment, and where are we going to stay, school, daycare, childcare. There are so many components, and we like being the point person. When families call us and like, we forgot about this, or what about a nanny for our child, and it's like, well, I didn't sign up for this. I didn't learn this in grad school, but we figure it out, and then we have these resources, and then we're able to help the next family. So, all right, okay. And during hospital stay. So yeah, again, frequent check-ins during hospitalization, facilitating coping. This is one of my favorite parts of the job, because the hospitalization, in my opinion, is one of the more intense phases of the treatment. And I like checking in on patients and really getting a sense directly from patients and their parents, how are you doing? And what ways could we support you in your coping and your conceptualization, so you can cope effectively with the hospitalization. And yes, there's situational depression and certain anxieties that are normal. But my question is, what could we be doing for you to aid in your hospitalization? Because there's a lot to be done during that phase that could either impact a smooth transition out of the hospital or delay hospitalization, right? And because sometimes we see with the teens and adolescents, adherence could be a challenge, whether it's medications or therapies or physical therapy, and just trying to boost, morale and motivation in any way we can by using counseling interventions. and supporting caregivers more importantly, because when you have healthy caregivers, that plays a huge role on the patients, because they're doing the bulk of the work. The caregivers who are there administering medications, opening the blinds for patients, getting the sunlight in, making sure they're eating, walking, and doing all of that. So the more we support the caregivers, we're doing a big service for patients as well. So, and again, working closely with the integrative disciplinary team, we meet weekly, consult on all the cases, and again, I kind of go back to that first point. We all have this shared goal of supporting the patient through their treatment and having the best outcome, and really bringing our brains together and say, what are you doing? What are you working on? Oh, okay, well, what could I do? And even sometimes even scheduling, saying, okay, Megan and Mo are in there Mondays and Wednesdays. I'll try to come in on Tuesdays and work on this, and really trying to measure, okay, how effective are the interventions we're doing. And if a patient's followed to transfer to the PICU or having some acute changes, we're consistent and we follow them throughout their stay, no matter where they're at. And that's one of the things I appreciate about the role. And prior to discharge, again, it's counseling support and education. And just, we help with some logistics. Okay, so-and-so needs a wheelchair, a commode, things like that. And working through the anxiety related to discharge, very, very normal. You have, okay, these people have taken great care of me. We've done well up until this point. And now you're telling me I have to take my child to the community, and then I have to be the one to administer the medications. That could be a very, very scary thing for parents, and just supporting them through that process. And on the outpatient setting, we're doing a lot of check-in and clinic, and providing ongoing psychosocial support, counseling, resources as needed, and facilitating coping with complications. So just because someone's out of the hospital doesn't mean they're doing fine. And we always try to keep that framework, because someone could be out but struggling with GVHD. We don't want to assume that they're doing good. We want to provide them with the adequate support, and continue to do appropriate referrals and things like that. Any questions or comments?
So I don't see any specific questions yet. I anticipate there might be a few that roll in. But I didn't know if you wanted to share a little bit about, you kind of alluded to this, but when people go home, what kind of services do you guys provide, or do you provide follow-up or referrals to services in their community after transplant?
Yes, so because of the broad range, there are patients from all different states. We may not be experts on like Philadelphia or Texas, but we like to coordinate with the home social worker. So they'll have a primary PCP that will say, okay, once John Doe gets back to Texas, we're going to look after him doing his blood work. He'll be in once a month. Typically, most cases, there's a social worker as part of that team. And what I like to do is always do a soft handoff and say, John Doe is going back to your facility there, doing follow-up once a month. And most times that social worker says, thank you so much for the information. I'm going to check in with them as part of their visit. And sometimes I'd say, okay, this person did great with counseling here, or they just got started with a psychiatrist here. If that's something that you could maybe do a referral for a local provider, that would be beneficial. Things like that, or even saying, hey, the parent just lost their job. If there's any in-house resources you can provide upon their arrival, that'd be beneficial. And even some of those small handoffs, we can't do it all the time. So I always kind of go in like, I'm not going to try to manage things I don't know. There may be programs down there that I'm just not aware of. It's best that someone on the ground there that could assist the family take over. So that's kind of that's the approach at least we take in BMT, because of just the broad range of patients.
Right. Yeah, that would be a lot for you. Have to coordinate everything on the other end as well. That would be very challenging. But I'm wondering if Kyle could maybe speak to that aspect as well. When he did leave BMT, what that was like going home, and then did you feel like there was any gap in resources or referrals, or did you have what you needed?
Yeah. When I got home, I know that I wanted to transition to doing a lot of the same things that I was doing at the University of Minnesota at home, as in like still retaining massage therapy, still because well, my integrative therapists were also serving a dual purpose as almost like psychologists. I know that wasn't in their job title specifically, but they definitely were. Uh, and what I had found upon going home was that a lot of the local uh, healthcare physicians were really not just healthcare physicians, but like local psychologists were really unequipped. They just weren't really, they weren't used to dealing with someone with a complex as medical history as someone like me, or someone as young as me dealing with these type of medically complex issues. Because the same advice, and not shouldn't say advice, but I think the same way that you would approach somebody like in their 60s or 70s dealing with, you know, really severe health problems isn't quite the same way as maybe you deal with somebody that's in, you know, pretty much a teenager or in their early years of adulthood.
Mhm.
I found many of them just, I did eventually find somebody though. And I think what the big separator was that the person that I'd finally found was willing to listen, like do a lot of listening and willing to realize that, hey, I don't know a lot about this, but I'm, you know, here for you and I'm going to take pretty much what you tell me. I'm going to digest that. And, you know, I'm not going to exactly tell you how to live your life, or I'm not going to give you like a concrete action plan, because a lot of them, they didn't know a concrete action plan for somebody that was, you know, having to take 25, 30 plus pills a day. I can't just go out and I can't just go out and socialize with people when I didn't have an immune system. Cause that's a lot of their advice would be, oh, you just need to get out more. I remember hearing that originally when my first few psychologists that I'd went to, and I'm like, you know, that's just not really that great of an option for me because there's so much risk involved with, because going out to, you know, with going out to bars and stuff like that, or going out and socializing and going into these social activities because of my weakened immune system. But I did finally find somebody that I felt gave me what I needed, and I really didn't even know what I needed. I was still trying to explore what exactly I needed, because I didn't know. I was just reaching anywhere I could for help, and not to mention our the system right now is so broken and so overwhelmed by people with mental health issues that it's extremely hard to even get into a lot of these places without having a 3+ month wait time. And, you know, I wasn't ready to wait 3+ months. It actually got to a point where and this was before I finally found a good psychologist, but where I had checked myself in at the University of Michigan into their psychological department, and I stayed inpatient for about a week. So I had to take the emergency route because I knew I wasn't going to get the help when I needed it. And I was in a very, very bad, fragile state of mind. And that inpatient about week that I spent inpatient really did help me too, because I went in there and I got to interact with people that were not going through the same exact thing as me, but they were going through really, really serious traumatic things. And there were people there that were there to help us process it. But what helped process, I think, a lot of these things most of all were the people that were also going through it, that were there to receive help. I remember like, you know, getting help from just being able to talk with these people and like understand their problems a little bit better. It helped put my problems in perspective. Not to say that I was minimizing what I was going through compared to what they were going through, or vice versa, but it was just really good to be in the presence of somebody that had really felt the how bad it can get. Because once you go to the very rock bottom, I feel like you kind of come back even while you're at that rock bottom. You just have a greater understanding of what other people are going through, not like you've gone through the same exact thing, but as in like there's just an energy that a lot of these people had that was just really comforting for me, just to know that I wasn't alone, even if I wasn't going through the same exact thing. But it was a very, very, it was difficult. It was extremely difficult to finally find the help that I needed. Uh, and even to this day, I still I am much better off now. I'm much better off now. And I can talk a little bit on isolation. and how I really believe that isolation and loneliness are two different things. They're interrelated, but they're two different things, as in one can be isolated and not be lonely. It's difficult, and it requires really one to look into oneself a lot and try to do these different grounding activities. And yeah, it's not a one size fits all for that, but there's definitely a difference between loneliness and isolation, because I've been isolated and not felt lonely, and I've been not isolated and have felt lonely. And to me, they're interrelated, but they're not exactly the same thing. One can be isolated and still be decently well off, as long as they're taking the extra steps to try to find themselves, and also connecting with people around them, if that has to be through, virtually or whatever. But yeah, it's definitely a complex road, and I know there's some really good things coming ahead, though, because I know Megan and people at the University of Minnesota have been working on a website that would be able to connect people after their transplant with these care providers, and with people that know exactly, kind of, not exactly, but they know what they're going through. They know that, this is they're going through an extreme case, and they can acknowledge that. A lot of the problems that I had with the early people that I was seeing, that they just weren't able to exactly see how serious it was, or they weren't really able to grasp it, because they hadn't known anybody, intimately, that had went through problems like this. And maybe if they were in their 70s or 80s, but not somebody in, between the ages of 18 and 25. So, yeah.
Thanks, Kyle. I'm so glad you mentioned the Survivorship Project. I wanted to bring that up if I can say a few words, Jordan, but if there's a lot of questions, I don't want to take up too much time. Many of us at the University of Minnesota have been involved in a project really over the last 18 months. We've worked with a user experience group and done focus groups and individual interviews with our patients and families who have been through transplant, and asked them a series of questions about what is the hardest part and what resources are useful and what resources are missing. And sort of the initial hope with that was that we would kind of uncover ways that us as the integrative therapy team could help support people. As Kyle mentioned, he relied pretty heavily on integrative therapies when he was at the University of Minnesota. And then when he went back home, he found a lack of availability of that same support. And then you really realize the gap of kind of the safety net it's been providing for mental and physical health. And so in addition to learning a lot about how integrative therapies could help in that transition home from transplant back to kind of, a sense of normalcy in home life, what we also uncovered was that there is a very, very much a lack of mental health services. That was sort of the findings that we didn't necessarily expect, and they came through pretty loud and clear from our transplant survivors that we talked to. So many people, I think, at this conference today and Gabe have been a part of this project. And so we've been in the background behind the scenes developing resources that will be on a website that's actually launching hopefully in July. We're very close, that will offer some information on these topics. And, we have a lot of high hopes for what it could eventually become, as Kyle said, a place to connect, some peer-to-peer support. So ideally down the road, we hope that it also becomes kind of a telehealth hub where you can even dial in and get mental health services and supports from wherever you are, whatever state you're in. One good thing I will say of COVID-19 is that telehealth has been a challenge, and insurance hasn't always wanted to pay for it. And guess what? COVID-19 did help propel us into the 21st century, where all of a sudden people figured out how to make telehealth work. So that is the good news. That may accelerate that side of the project. But exactly to Kyle's point, we're hoping that we can have a community of resources that transcend the barriers of space and time in different states and different insurance networks to continue to support people as they reintegrate into their pre-transplant lives after having had this monumental experience. And one of our families that's also been deeply involved in this project is the Breningers. And Allison, you all know her writings, I'm sure, from her involvement with FARF, and then also her own writings on the negative space. She has been writing some really important pieces for us, and just participation from the whole family. So I will put the call out that if you haven't already been tapped to participate in the website in one way, shape, or form, and you're interested in learning more or interested in contributing your story, we are looking for this resource to be for survivors by survivors. And really, we see ourselves as just the platform and the people who take all of your collective wisdom and sew it together in a way that makes it accessible to all. But we rely on all of you for the depth of content. So I'll put my email address in the chat, and please reach out if you want to know more about that. Otherwise, Jordan, if you're open to it when the website launches, I would love to share it with FARF and have you share it through your social media networks to reach this audience.
Yeah, absolutely. I'm so glad you shared about that. I was wondering about that. And we've talked a little bit about that. And I'm so excited for this website. I think it's exactly what this community needs, but so many other, communities. That kind of ties into a couple of the comments that were on the chat. Just Donna had said, yes, it's been re-traumatizing after transplant for me because of the separation from family and then feeling stuck, unable to move forward with life. And I think this project that you talked about and also what Kyle just spoke about really paired, I think that is all interconnected. And I think that the resources that you guys are creating are going to really help alleviate some of that.
Yeah, thank you. I would say to that person, I didn't catch whose comment that was, but to that person, I would say you're not alone. The number one thing we heard during that needs assessment was that transitions are the hardest part, whether it's transitioning to transplant or transitioning home, or being told you should be transitioning back into normal now, but everything's not feeling normal yet. So transitions it's a tough area to think about how to tackle and provide comprehensive resources for it, but it is top of our priority list. So stay tuned for more resources on that.
And just to clarify a little bit, Jenny had posted a comment that said telehealth isn't really an option for some of us in different states. We can't meet with psychiatrists from Minnesota. So would your program alleviate some of that, or could you see potential barriers still coming up with that?
That is a really good question. I would say we haven't gotten to the point of working through all of that yet, but I think what Gabe and I know to be true from the work that we currently do is that we're lucky in PEDS BMT in that we're kind of a bundled package, and once a BMT patient, always a BMT patient, and we're there to serve you. And so if you've been a part of our program, we're going to continue to be there to serve you. And so I don't necessarily know that our website would host psychiatrists and psychologists so much as support from nurses who are specialized in this type of work and social workers who are specialized in this type of work, and staying connected to some of the people that were helping you during BMT. And so creative ways around billing and credentialing, I think, is what I'm getting at. But I'm really glad that you brought that up, and I will be looking more into that to make sure that we have really creative ways of getting around that. And the other piece I will say is that I'm working really hard with philanthropic donors and supporters like Children's Cancer Research Fund to make sure that whatever we create is accessible to everyone and doesn't rely on insurance or ability to pay. And we're looking at having things like family scholarship funds available. So whatever services are a gap in your insurance care, it just becomes a non-issue, and we can connect you with what your needs are.
Gosh, that will be so amazing. So that kind of ties in nicely to Sean Breininger just posted, and he said he went through BMT as an adult, and resources and supports for well-being of adults are far fewer than what's offered for children, young adults. Adults advocate for your services for yourself because they likely won't be automatically offered. And that's a question I was going to ask both you and Gabe as well, a little bit earlier, but are your guys' services offered to adults in the hospital, and how do they access your services if they're not automatically offered?
Yeah, thanks, Sean, for your comment. I think it's a different answer for Gabe and for I, as you know, social work support I think is pretty similar on the adult side. Gabe can speak more to that. no one like me or the rest of the integrative team exists on the adult side, unfortunately, at this time. But everything that we're creating for the Survivorship Project is for, I should be clear, it's not just for FA patients and families, it's for a larger survivorship community. But we are looking, aiming our first set of interventions at teenagers to young adults, and I mean young adults broadly. So we're not turning anyone away based on their age for these extra support services that will be coming.
I would say our model on the adult side, so for patients who are transplanted on the adult side, there are still social workers there and they follow them. Again, the adult population, I think some of the needs are a little bit different, but certainly the resources are. So I would say we, on the pediatric side, there's more accessibility to resources. And so that is something we're aware of, and whenever we get together with our adult counterparts, they've mentioned that in past meetings that, you know, that we're limited, but we want to do more for our patients. So yes, they're acknowledging there's some concerns. For instance, even if you take child psychology, like, so we get a referral, someone could see the patient in the hospital. And on the adult side, that may not happen just because, you know, it's just, they don't have the availability of staff. They don't have a psych department that could just go room to room and see people. So there's that gap in services for sure.
Mm-hmm. Yeah, none of it's for lack of want or lack of trying. It's just, it's incredibly hard to work within our system to always do what's right to meet all of the needs. And, you know, to be quite frank, Dr. Wagner is the reason that we have as much as we have on the pediatric side. He had a vision, you know, about 7 years ago, and he brought me into it. And I don't think he even fully understood what was needed, but he knew that there were gaps. And so he put his money where his mouth was and got services started. And then one thing's kind of led to another. And now we have a pretty robust complement to the kind of standard of care like chaplaincy and social work that's been in place and is in place in a lot of transplant centers.
Yeah, thank you so much for addressing those things. I have a question. So are you guys in communication with other transplant centers as far as what services are offered there? Like, can you speak to maybe what other services might be offered at other centers? I know not specifically probably, but are these types of services offered at other centers as well?
I can talk a little bit. So once a year we do a association of pediatric oncology social workers, a big meeting and conference, and all over the country, Canada, we get together, and that's usually a good opportunity to say, okay, what's your transplant center doing? Oh, well, here's what we're doing, and just trying to understand, okay, what's happening, what, like support groups. 2 years ago, that was a big theme. It's like, we're doing this and it's great, and that kind of led to, you know, coming back to Minneapolis and saying, well, should we be doing this? And then it ended up like we had an intern, and now we have that. And so we're always trying to kind of have a pulse on what are the most effective kind of resources and what kinds of programs could we implement. And then just even like in regards to caregiving, like we had a center that goes out and does a caregiver assessment in the home prior to transplant. We were like, we're not doing that, but that's unique that you do that. So we did bring it back, and it's like, no, we're not going to do that. Oh, gosh.
Yeah, and from the integrative health lens, looks like Gabe froze, so I'm just going to take the baton. It's a little more variable, and I don't have a good finger on my pulse of all the transplant centers across the nation, especially those that specialize in FA. But in general, integrative health ebbs and flows because we're less supported by insurance, and it can be variable how integrative health is funded. And so it really does take a transplant center kind of investing in it because they see the value in it for their patients. And it's one of those things where the outcomes are pretty intangible. I mean, you all heard Kyle's very powerful story of how impactful it was for him to work with integrative therapies, but we've been trying for years to kind of capture that data and put it into research protocols where we could actually have the data analytics to support. We know that integrative therapies lead to X, Y, and Z, whether it's outcomes or cost savings. And it's really hard to do because they help people on a really personal level. And some of that can't be captured in statistics. I mean, sometimes I meet with my statistician and I tell him the struggles of the data collection, and he sort of looks at me like I have 6 heads, like he doesn't know how to make sense of it either. And that's a common theme because, you know, research is reductionistic and tries to drill down to a cause and effect that is, you know, beyond a reasonable doubt scientifically true. And taking an integrative lens to a care model is quite the opposite. It's looking at a person as a whole being who's complex and intertwined with their family systems and the healthcare system and these trillions of variables. And part of what a talented integrative therapist does is figure out who that whole person is and what makes them whole and partner with them to get to that place. So it's not always the same intervention. It's not always the same outcome. And sometimes you can't even put your finger on what the outcome is. But, you know, if you feel better and you're thriving and you're able to get out of bed and participate in your life better, well, then that's made a big difference. But because it's so complex and different for every individual, it's very hard to kind of prove the case for it.
Yeah, and that's kind of like FA too. It's just so different in each person and so complex. So thank you for speaking to that.
Well, I think that's the beauty of these organizations like FARF and Children's Cancer Research Fund, which I work closely with a lot, is I think people in these organizations have that broader lens and understanding, and they do incredible work to fundraise and support those ideas that sometimes fall through the cracks of the other conventional system, you know, ways of the conventional system values services and pays for services. So thank you for all the work that you're all doing with FARF.